Okay, excellent. Let's get started with the afternoon pelvic pain session. My name is Andrew Schrepf. I'm a faculty member at the Chronic Pain and Fatigue Research Center. I am just going to be hosting today because I am incredibly fortunate, and I asked the three most favored pelvic pain researchers that I know if they would talk today, and they all agreed. And I feel like the kid on the playground who never gets beat up because of his three big friends. Um, and, and I'm really excited about this. So first up is going to be Jason Kutch. He is an associate professor in the Division of Biokinesiology and Physical Therapy at USC. And Jason has done incredible work with neuroimaging and pelvic pain through the MAP network and other resources for a very long time. And I'm going to stop talking and let these brilliant people wow you. One note, we will take questions all at the end in a panel session after our three speakers have gone. So that, Jason, welcome.
All right. Welcome back. How's everybody doing? Good to see everybody. Last time I gave a talk, I was up in Toronto. I was talking to Karen Davis in a group, and right at the beginning, a cell phone went off. Was playing like a really great tune. I forget exactly what it was, and it was really exciting because I feel like as scientists, we never get to like walk into great music, or everybody else does. But so I was very thankful that cell phone went off. Yeah, I'm Jason Kutch. Delighted to be here. It's a bit of a happy homecoming for me. I did my PhD work here at the University of Michigan, and then have had the good fortune to be able to work on pelvic pain for the last 10 or so years. Something that's going to be relevant later on in the talk is that when I was in my 20s, I developed a series of chronic overlapping pain conditions myself, starting with migraine, and then chronic spine pain, and finally chronic pelvic pain, which has been the focus of my research. I can testify, I think it's been great that we've had the patient panel, because I can underscore how incredibly frustrating these conditions can be. And fortunately today, I live pain-free, and there's a bit of a twist on that at the end, and a little exciting study that was inspired by my experience. But first, I'm going to talk a lot about the MAP Research Network study, and I wanted to thank a lot of individuals that have participated in that study, particularly Andrew. We've collaborated a lot over the last couple of years, and it's been really fantastic. Natalie McLean, who's up there at the top, is a PhD student, really great, and she's going to be featured today. But this study would not be possible without the efforts of an enormous number of people who were part of the MAP Research Network, and I have a huge debt of gratitude to Dan and all of the others that really put that together and made it happen. Yeah, it's been really an honor to lead the neuroimaging efforts in that network. I have no disclosures for funding. I'd like to thank the NIDDK, as well as some new funding from the HEAL initiative through NINDS. So we're going to be talking a lot I'm going to be talking about urologic chronic pelvic pain syndrome. This puts together interstitial cystitis and painful bladder syndrome, along with chronic prostatitis and chronic pelvic pain syndrome. We saw some of the prevalence data from Dave Williams yesterday. Suffice it to say, this is affecting millions of individuals in the U.S. And I think all chronic pain is very impactful in different ways. The thing that makes chronic pelvic pain so insidious, I think, is just the body region it affects, the functions that it affects, the relentlessness with which it is present. And so a lot of fundamental activities of daily living, something simple as resting or bladder function, sexual activity, even sitting in a chair, become just excruciatingly painful. Sufferers report lower quality of life compared to other prevalent pain conditions. And so, the NIH sponsored the multidisciplinary approach to the study of chronic pelvic pain, or MAP Research Network, which was really a groundbreaking study across the U.S. to try to understand the biology of these conditions better. My role in that was particularly to try to understand the imaging data as best as possible. So one of the main findings of MAP is that these bladder pain syndromes don't exist in a vacuum. They're a part of the greater cluster of chronic overlapping pain conditions that Dave spoke about yesterday. So they're listed here. And I've sort of just done a rough body map of where these different chronic overlapping pain conditions occur across the body. Many of you have done fantastic work to understand that these conditions are already much more challenging clinically and an important hypothesized indicator of a central pain amplification process. So to get at that, Rick Harris and I started several years ago now and published work looking at what we called the brain signature and functional impact of centralized pain. I want to use that to set the foundation for some new findings that I'll describe to you today. And so, like I said, MAP had found that chronic overlapping pain conditions were incredibly common in UCPPS. And as pain became more widespread in UCPPS, it didn't do so uniformly, but it follows the distribution of COPCs. And so what I'm showing you on the top there are body maps. They've been broken up by the number of painful body regions across the body, from very localized pain, only a couple of regions being expressed that are painful, all the way up to the greatest tertile, which has a lot of conditions expressed. And as pain becomes more widespread on the body map, there is a concomitant increase in the both meeting diagnostic criteria for these chronic overlapping pain conditions, as well as meeting survey criteria for the chronic overlapping pain conditions. And I think that's an important inspiration for Andrew and Dave's work on the COPC screener. So the idea here was to say, okay, these are all pelvic pain patients. What is different structurally and functionally in the brain in the patients that have widespread body pain compared to those that have more localized pain? It goes to, I think one of the really nice pieces that that Ted hit this morning is that it's really important to be able to push neuroimaging forward and make it more useful in the chronic pain space. It's nice to compare patients and controls, and we did a lot of that in MAP, but it's also important to try to understand differences among patients that are considered to be clinically relevant. And so what we found was that the most consistent findings that kind of naturally appeared in this data set were both structural changes. And so I don't know if I can get the laser pointer here. Sorry for the delay. Okay. So up here, we're looking in changes in gray matter volume. And these are increases in patients with widespread body pain compared to those with localized pain. And so you can see there's this increase as you go from local to intermediate to widespread. And we validated those findings by comparing. The idea was that if it has to do with the widespreadness of pain and not the presence of UCPPS, the pelvic pain condition, then it should be validatable in another sample of individuals that have widespread body pain compared to healthy controls. And indeed, we were able to validate the same increase in fibromyalgia patients compared to healthy controls. On the functional side, what we found was the strongest indicator was an increase in connectivity between the salience network and this specific region of sensory motor cortex. And when we saw this, we scratched our heads in disbelief. This didn't make sense. These individuals have widespread body pain. There's a homunculus in the cortex. Why isn't the whole damn thing lit up or changed? Even the structural findings that are a little bit broader are still relatively localized. They don't really stretch all the way around the homunculus, even though individuals are expressing pain pretty widespread in their body. I'm going to show you that this replicates if we look at it in a different way with even more powerful techniques. And then I'm also going to provide a potential explanation for why we're seeing widespread body pain map to such a restricted area of sensory motor cortex. And I'll show you a little bit of RTMS data about how we might be able to modulate that. So again, this same functional finding also validated in patients with fibromyalgia compared to healthy controls. Okay, so this was exciting, but then I'm really grateful that Chelsea and Rick kind of looked at these same changes in the ABCD study. And I was obviously blown away beyond belief and so happy to see that something very similar was emerging in the adolescents and even before they start expressing pain. So in Chelsea's fantastic paper on predefined or pre-existing factors that may be antecedents of the emergence of widespread body pain, you see the same kind of change, increase in salience network connectivity to this restricted sensory motor cortical region. And so that was really obviously very exciting to see. So we're talking about pain centralization, which is the central amplification of pain. We never would tell patients that are coming into my clinical trial for RTMS, I am very careful to never say that we're going to stimulate your brain. This in no way indicates that I think that the pain is in your head. I just want to understand, is the central nervous system playing a role in amplifying your symptoms? And usually patients really buy into that concept. They kind of buy into the concept that there's something going on peripherally and the amplification knob could get turned up, as Dan's analogy goes, and create a greater pain experience at the level of the nervous system. And so to really refine this, I want to think about different approaches to inferring pain centralization. I don't think there's any one-shot approach or there's any perfect approach. I think there's a combination of approaches that we can use to better understand pain centralization. One, of course, is quantitative sensory testing. I think it could be very useful, but it could be sometimes difficult to match to the patient's chief complaint. There are, of course, animal models that gives you some mechanistic insight, but there are obvious challenges in making direct inference about chronic pain in humans. And what I want to present today is this idea of kind of using natural fluctuations in pain intensity to understand a little bit more about the pain centralization process. And it goes something like this. Even if you were a perfectly healthy individual that had no pain centralization at all, you would have, as your pain scaled up, even if it was driven totally peripherally, as your pain scaled up, some particular pattern of brain functional connectivity would also scale up. But what if it scaled up a little differently? What if there was a modifying factor that changed that relationship in one person compared to another? You could say, okay, there's just inter-individual variability, no big deal. But what if that shift had something to do with a phenotypic factor that was already known to reflect what we think is centralized pain in some way? Then I think we can start to build the case a little bit more that this is maybe a representation in the nervous system of part, I mean not all, but part of the amplification process. And so that's what Natalie McLean has been working on, my PhD student, in a large sample of 492 patients with UCPPS. This was collected as part of the MAP2 longitudinal study. These patients were imaged at up to 4 time points over 3 years, baseline 6 months, 18 months, and 36 months after the visit. And so what we map out is the pattern of pain fluctuations. And when I'm referring to pain here, I'm talking about their genitourinary pain intensity in the last week. So in the week, at the time of scan, they're asked, how bad were your pelvic pain symptoms over the last week? They rate that from 0 to 10. And you can see a couple of different patterns. It's pretty consistent across the sexes. You can have individuals that have highly stable pain, so individuals that are sort of always reporting the same level of pain, be it high or low. You can also have individuals that have highly fluctuating pain. And I can attest that personally, this is a very real experience of chronic pain patients. Some days you're at a 7. Some days you feel just fine. Other days you're somewhere in between. And so what we're going to do in this study is kind of try to exploit these within individual patterns of fluctuation to try to map out a little bit more about the neural circuits related to pain. Before I get to that, I just want to say they are impactful. These aren't just random fluctuations. And we can verify that in 2 ways. One, it affects mental and physical function so that basically the higher your pain rating is, the worse your physical and mental function is on this metric. And then the patients that have higher pain also tend to be those that report themselves to be in a flare-up state of their symptoms. So if we look at the neural correlates of pain, we looked at resting state functional connectivity using 2 different atlases. I thought Ted's talk was a great intro to this talk about all of the things that you can do wrong, and I've definitely done things wrong in my neuroimaging career. But fortunately, this is a longitudinal within-person model, and so it's kind of trending towards hopefully that better application of neuroimaging that can get around some of those problems that he discussed earlier. And then what we do is we basically model the functional connectivity values within a person over time, controlled for age, sex, site, and a couple of other factors. And what we identify is connections in the sensory motor salience and default mode. And if you picture this, basically the size of the sphere tells you how many pain-dependent connections does that region make. And then if you look at this pattern, you can kind of see something that is pretty similar to what Ted showed in his meta-analytic analysis of the neural correlates of pain. And I'm going to make that a little bit more concrete and a little bit easier to see. So what some of the early things that he showed, I actually wasn't aware of the most recent work that he did, so I can go back and look at this again. But some of the very first graphs that he showed were from Neurosynth, which is a little bit of an older meta-analytic tool now. But this is based on 516 studies of pain, and this animation can show you the different regions that pop up across those different studies as related to pain. You have thalamus, you have salience network in purple, you have the blue regions, which are sensory motor regions. And so you can see that there is this pattern that looks pretty similar to what we're seeing in the map longitudinal analysis. I'll just spin this a little bit so you can get a sense for it. And then I'll rotate this one as well. So you can see there's a little bit more going on, but the same kind of core pattern of bilateral insula, sensory motor connections, a lot of common features are happening between these two, what we would expect for acute pain and what's happening in this map longitudinal analysis. So now let me say a little bit about this phenotypic analysis when we said what factors might modify this relationship between connectivity and pain. We looked at the presence of widespread pain, the presence of neuropathic pain, anxiety, depression, and catastrophizing. You may think that all of these things are kind of the same, but they're not. There's a lot of independent variance between these different features. And so what we did was we kind of built a model, an interaction model, to see which of these factors was the strongest modifying factor for the relationship between genitourinary pain intensity and brain connectivity. And it turned out that of those 5, it was only widespread pain that had a significant effect, and it had a very strongly significant effect on lots of regions in the brain. The most interesting thing, I think, is when we overlap the connections that are pain dependent and the connections that have this modifying factor with widespread pain. And this is the map that's carved out in that case. And you can see that we have not a uniform distribution of these regions across sensory motor cortex. Again, we haven't spanned out the whole homunculus. We're still localized to a couple of these specific nodes. This is the one that Rick and I have found, and that was replicated in the ABC, or generalized in the ABCD study by Chelsea. This is a medial wall region. There's this kind of an intermediate region here, and then these really big ones as you get over to the very lateral part of cortex. And my tentative explanation for this is that there are important spatial homogeneities in sensory motor cortex. You may be familiar with the paper that was just published by Nico Dockenbach in Nature, where they're reconceptualizing the classic homunculus by actually this homunculus that's broken up by these things that they call inter-effector regions, which have 2 interesting properties. They're more connected to each other and to networks like the salience network. And they also don't activate in a task-specific way. They tend to co-activate with lots of different tasks, unlike these effector-specific regions that only turn on with very specific tasks. They obviously did a very beautiful job with this, but I think that it confirms in some way something that we actually published a couple of years ago, where we took salience network, and we mapped it out onto the cortical surface. And we extracted both sensory and motor cortex, which you can see cut out there. Motor cortex along the top and sensory cortex now is on the bottom. And you could see these really nice patterns of inhomogeneity, which I think line up pretty well with these inter-effector regions. And we actually replicated that also in a couple of cohorts, both the 1,000 functional connectome data and then in MAP with purely pain-free individuals. So this is not a pain-specific effect. These inter-effector regions are likely in even healthy individuals, but it may start to possibly explain some of the phenomenon where patients with widespread body pain have changes that are specific to these regions because it has more to do with these inter-effector whole body representations than it does spread across all of the motor cortex. In the last couple of minutes here, I'll just mention very briefly, in my current clinical trial of RTMS, we've been looking to see if we can modulate this connectivity between sensory motor cortex and the salience network. This is very preliminary in a sample of 7 individuals, but you can see when we stimulate this region with high frequency TMS, we're actually reducing the connectivity between that region and relevant salience network regions. And so patients with widespread pain had increases in this connectivity. We're potentially at least driving it in the opposite direction. And I hope that we're going to learn a lot more over the course of this clinical trial. So last 2 minutes here, I want to tell you briefly about a study that I'm very excited about. I think brain stimulation has a lot of promise, but there's a lot of free parameters. It's very difficult to work out exactly what to do. I'm also very interested in immersive activity for pain. And the way that I was able to eventually get over chronic pain myself came from the unlikely activity of surfing. And so surfing had this effect of taking my pain from wherever it was down to 0. Not 1, not 2, 0. And even on the days I wasn't surfing, eventually I started to recognize, oh, there's this thing that I could do to control my pain, and so I'm not so worried about my pain anymore. I thought, okay, that's just something specific to me. It's great that I have an activity I can do. Everybody's got an activity, nothing to study here. But I encourage you to take 25 minutes if you ever have a chance and are interested to watch a beautiful documentary on Netflix called Resurface, which is about using surfing therapy in patients with PTSD, specifically veterans with PTSD. And so I put together a multidisciplinary team of engineers and neuroscientists and other people at USC. And we got a pretty decent size multidisciplinary CTSI grant to explore this for chronic pain. And I thought initially that maybe some of the university administration might meet this with skepticism. And in fact, I got exactly the opposite, including a tweet from USC's president about how we were doing this very cool study. So just in the nuts and bolts of it, it's called the Neuroscience and Engineering of Ocean Wave Surfing as a Therapy for Chronic Pain. We've just recruited the first group of 6 very willing and eager participants who are excited to do this, that all are patients with chronic pelvic pain, but additionally have chronic overlapping pain, at least one additional COPC. And so we scan their brains with fMRI at baseline, and then they're going to go for 4 sequential weeks of a structured ocean surfing therapy program that we're running in Southern California. And we're actually going to record an electroencephalography or EEG at the beach using this Muse device. And the other thing that we're going to do is that surfing suffers from this problem of it's restricted to the ocean. Is it really scalable? All of those other things. So with my engineering colleagues, we're going to engineer hopefully will be the world's greatest virtual reality surfing environment. So we already have fully immersive VR. I've written a very cool wave simulator in VR, which has been kind of fun. And within the next few weeks, we're going to be able to attach it to this really high-performance motion platform and start to explore. And we're going to have the patients come in. So we're not going to design it in a vacuum. We're going to have the patients come to us at USC, test our VR environment, say, hey, is this similar to the experience that you had in the ocean? How can we make it better? Does it induce any motion sickness? and really kind of iterate it with them. Not to convince you of anything. This is, hopefully a preliminary study that can show more, but just for, total proof of concept, we did it in a couple of individuals with chronic pelvic pain. And this is their pelvic pain rating before and after surfing in a couple of different sessions. I ran this, they ran this independently of me. I didn't want to bias it at all. But the results, I think, are very similar to my own experience. So I'm excited about how this could be used. I think we want to understand more about interventions that can do this and understand what are the neural changes that can do this, so that even if it's not ultimately surfing that does that, we can learn more about the neural architecture and the neural changes that can produce these really dramatic reductions in pain. So to wrap up, I'm really excited about what map neuroimaging allowed us to do and map the brain to look for convergent evidence of dysfunction. These salients and these particular hotspots in sensory motor cortex seem to be the ones that display the most apparent dysfunction and are providing this foundation for future RTMS or current RTMS and maybe other clinical trials. Lots of open questions about, is it these inter-effector regions that are really mediating widespread body pain? And then what's the best way to improve these changes and reduce pain? Is it RTMS? Is it an immersive activity? Is it some combination of those? Lots of open questions. So thank you so much for the time and really appreciate your attention.
All right, thank you so much, Jason. That was awesome. And next up is Stacey Mismer. She, in some ways, needs no introduction because if you have studied pelvic pain at all, you're going to run into her work very quickly. And luckily, she is one of the kindest, most brilliant, and generous colleagues that I've ever met. And so I'm very, very pleased to welcome Stacey, who will talk to us about some of her work. She is a professor at MSU in OBGYN and reproductive biology. All right, thank you.
Thanks, Andrew. So I am the questionable filling in the neuroimaging titan sandwich for the seminar. So I am going to, here we go. All right. I'm going to do basically an overview of quite a lot of different lenses we're taking to explore pelvic pain, and in particular, pelvic pain over time in an adolescent cohort, and then describe a little bit a new cohort that we have developed. Just again, to stimulate discussion and also recognizing that there's such a diversity of expertise and interests here at this wonderful course. So endometriosis, for those of you not working in this specific area of pelvic pain, is a condition where tissue that is like the endometrium is growing at other places in the body, primarily within the peritoneal cavity, but it can also be found in the lungs and brain and heart much more rarely. And we estimate that there's about a 10% prevalence. That really is based simply on who is diagnosed, and I'll get to some of those impacts and barriers in a second. But what we know for endometriosis is, although it is diagnosed primarily, the peak is between age 32 and 35. This is pretty consistent across the globe. We know that actually the majority have their pain symptoms and presenting at first for pain symptoms much younger. So most patients, particularly those presenting with pain, start to experience their pain in adolescence, and about 30 to 40% right around their first menstrual period or soon after. And so we know that it's hard to diagnose in part because the symptoms are non-specific. We know that models trying to use symptoms as a predictive algorithm to be used in the clinical setting have not been successful. We also know that menstrual pain is the one type of pain that's considered normal. And so what is the threshold for needing further evaluation and further intervention? We also know that there's a lot of embarrassment around menstruation and discussion of periods. About 2/3 of women report being uncomfortable discussing it with their primary care physician, just menstruation and menstrual health in general. And so All of this results into an average of 7 years from symptom onset to an endometriosis diagnosis. The majority receive misdiagnoses on that path, and it has huge personal but also health system impacts with a lot of engagement along the way to inaccurate diagnoses and inaccurate steps forward. And as Tanya Palermo so beautifully described yesterday, what we know for adolescents with unresolved and unaddressed pain and other life impacts, that it really sets them on a different life trajectory and frankly changes who they are and how they think about who they can become. We also know that endometriosis presents with multiple visualized phenotypes. And so this cartoon describes the 3 macro phenotypes. There's superficial peritoneal lesions, there are deep endometriotic lesions, and then there are endometriomas or cysts on the ovary. But endometriosis can present across this large spectrum. There is an American Society of Reproductive Medicine staging system. Stage 1 on the left, stage 4, high scarring and adhesions can emerge into what's called a frozen pelvis. Here's the fascinating part. No correlation at all with pain presentation. And so it's fascinating to me, and this isn't the focus, but the primary treatment, and Dr. As-Sanie is going to talk about this in more detail, but excision of the lesions is the kind of the gold standard primary recommended treatment. But honestly, I think the fascinating thing is that ever works, given that there isn't a correlation between what we see in terms of the lesion location, volume, and impacts within the pelvis. So there's very little discovery in adolescence. In 2012, we launched the 828 study from adolescence to adulthood. At that point, despite this emergence of symptoms consistently in adolescence, there had only been case series of adolescents with endometriosis and pelvic pain. And so we enrolled from Boston Children's and Brigham and Women's Hospital patients who had been surgically confirmed to have endometriosis. And then from the communities and adolescent health and gynecologic health clinics, the local catchment area. And then we have, since 2012 through 2018, when we had our full cohort, they at baseline complete a very detailed questionnaire with a lot of the pain scales and things and many other patient and other the behavioral characteristics that many of you, frankly, developed those scales. They do this at baseline. They also contribute blood, urine, saliva, and then we collect the same with somewhat dynamic questionnaires over time. We now have the shortest amount of follow-up is just over 4 years, and we have some patients who now are up to 10 years of follow-up. And so for this cohort, the average age of those with surgically confirmed endometriosis was 19 at enrollment. Without endo was 24. They're primarily white, non-Hispanic participants. This reflects the hospital catchment area. Also, both potential realities but biases in diagnosis of endometriosis specifically. And as won't surprise anyone here, there's a small proportion of those with endo who do not present with some other pain condition, defined very broadly, 15%. And then even among those without endometriosis, we're seeing about 60% who do have at least one other non-endometriosis pain-related condition. For endometriosis specific, we really are zeroing in on that stage 1 disease. So 96% are presenting with pain, and the age of symptom onset is 14. And then again, 95% with just superficial peritoneal disease. So at baseline, some of the discoveries, again, that will not be surprising to people here, but were novel for the endometriosis field, is that we saw those with endometriosis had 4 times the odds of also having migraines. This was robust to many different confounding controls and those things, so that the co-presentation was very high. We also, and I just wanted to use this example, because we're an outwardly facing adolescent-focused cohort, we try to present results in an accessible forms. So we have these, what we call visual abstracts. And so it's not that they have to be childish per se, but they have to be in lay terms. So looking at IBS, again, not a surprise at all to those in this room. We saw that those with endometriosis were 5 times more likely to have been either formally diagnosed or to meet criteria through the Rome criteria for IBS. Now, one of the things we're trying to look at is biomarkers and underlying physiology. So Naoko Sasimoto leads this work with Catherine Terry. So looking at the samples at baseline for plasma proteomic profiles. This is very complicated and hard to see, but just to say that across for red, the proteins that are upregulated with a panel of 1,300 proteins, in blue, downregulated. When we look, all of these participants have endometriosis, but then they vary in dysmenorrhea, acyclic pain, life-impacting pain, bladder pain, and bowel pain presentations, and we do see some different proteomic profiles. Also interesting is these are the pathways that are up and down regulated, comparing those with endometriosis who have widespread pain versus those who have just localized pain, and starting to see the emergence of some interesting patterns there. We also looking across time now, those were baseline data. Now we've cleaned the data and are starting to get the large enough sample sizes to look upon across time, again led by Naoko and also with Amy Shafrir, just looking at the descriptive data of the many, we have over 70 different pain parameters. So for example, looking among those with endo and those without, at baseline year 1 and year 2, we have very lengthy tables in this manuscript around the distributions. The first example is dysmenorrhea. The second is the proportion with life-impacting pain, and categorized as reports of different levels of inability to go to work or school versus having to lay down and be unable to conduct normal daily activities. But one of the things that's very interesting that's emerging is this is a Sankey diagram. So this is looking at specifically, it's just one example of acyclic pain reports across the 2 years, so from baseline to year 1 to year 2. In pink are those who at baseline on the NRS are between 7 and 10. In yellow are those who are 4 through 6, and then mild is 0 through 3. And as you'll see, we see basically all the patterns that mathematically you could consider across these 3. But there are those who stay at that severe level all throughout. There's a very small proportion of those who stay at the mild level throughout. And then we see these patterns that perhaps could be informative in terms of prognosis or treatment selection, perhaps in differing underlying pathways. And so one thing now that we're starting to look at is trajectories across time. This now includes up through year 3. So these are using trajectory classification analyses and using the physical component score of the SF-12. We see 3 distinct groups. Interestingly, for this SF-12 data, we see the same thing with the mental health component score as well. Pretty much the group you started in, and we've used this with a 3-group model, a 4-group model, a 5-group model, pretty much the group you start in, there's not that much change. There's some slowly increasing improvement, but this is across 3 years of follow-up of, again, an active clinical population. It gets a little more complex, but also more difficult to decipher when we look at acyclic pain over time. And so we have this group who had persistent pain. That's 47% of this population, all of whom had at least one surgery at prior to enrollment, most of them quite proximal to enrollment. We have those who had increasing pain across the 3 years. About 15% only had significantly decreasing pain. And so one of the things that we're trying to do is explore now what are key predictors of these clinically relevant groups. So what are the characteristics of those in these groups, and why or how trying to get at the underlying physiology. And so one thing that we're looking at now are what are those baseline characteristics. Amy, looking again at this, I'm just going to show you the SF12 example because it's a little more straightforward. Those things that are starting to emerge are, again, will not be surprising to those of you here, is that those with comorbidities and comorbid pain conditions are more likely to be in the slow increasing or the persistently low group. Though we're seeing relationships with sleep and disordered sleeping conditions. So just here simplifying, those who are getting less sleep per night are more likely to be in those lower functioning groups. And then those who have, whether they have the ability to or are engaging in physical activity as a beneficial behavioral activity, we're seeing that they have a per 5 METs per week, a lower likelihood of being in those lower functioning groups. And so also, we're now exploring these relationships specifically with change over time. And this becomes quite complicated because we have the change over time, but less correlated with the functioning, but very correlated with the pain expression is not only change in their own activities and behaviors, also change in their treatments, which are directly correlated with what their pain expression is. And so modeling this and teasing out and sort of attributing cause and associations with the groups is not straightforward. A key thing here is thinking about those mediators and what is the synergy between their own actions and characteristics, the underlying evolving biology as the emergence of or always existence of nociplastic pain, and then what those treatment interventions are and why they are and are not working, or whether they are started or ended because of side effects or other life choices, is all things that we're trying now to incorporate into these models. We're also looking from a much more bench-specific lens of assessing peritoneal fluid characteristics, the proteome proximal to the endometriosis in those with endometriosis. And then also, right now, we're just about to get back a bulk and also spatial transcriptome results from about 600 lesions from those in this population. So whether those marker characteristics of the endometriotic lesions themselves have a relationship here is something that we're next going to hope to discover. I also wanted to, I know that there's some experts, really renowned experts who've done some amazing work around genetics in these footprints. We, led by Karina Zondervan, are part of the International Endometriosis Genomics Consortium, and we just, with Nilüfer Ramioglu, published in Nature Genetics the initial finding of, across 24 studies of genes associated with endometriosis. The key thing about this finding is that we have found 42 loci. With this large sample size, 31 were novel. But we've also done MTAG or multi-trait analyses, and in the light blue there are those traits, the traits of the loci that we found most correlated with either immune conditions, patient characteristics, obesity, and anthropometry. In that light blue, those are the pain symptoms or other pain conditions. And so there was the most overlap for genetics, genetic loci between endometriosis and what is known for these other conditions. Also coming back, we did some sub-analyses looking at whether the loci remained associated with subtypes, and particularly splitting out by dysmenorrhea, acyclic pain, severity, dyspareunia, dyschezia, age at symptom onset, and saw some loci that were specific to those subgroups. One of the things that we're funded to start now is this study took the 42 loci overall and said, are they still associated with these subphenotypic groups? Now we're going to be starting with the subphenotypic groups and saying those with endometriosis and IBS, or those with endometriosis presenting with life-impacting acyclic pain, are there loci that are novel to those groups that didn't emerge in this original overall analysis? And then I also wanted to go back to this longitudinal in that one of the great things about this cohort, it's also a good group to now try to do sub-analyses around interventions. And so, for example, we knew from our clinical interactions and also from our questionnaire-based information that a lot of our adolescents were trying different dietary changes and particularly dietary supplements. So we did a small study randomizing 60 of these participants to omega-3, vitamin D, and then placebo. It was double-blinded, so we did not know who was exposed to what. We followed them over 6 months with daily dosing, and we could compare across time for the exposures, but then also between the groups. And what we end up seeing is we saw a significant decrease in many of the different pain scores for particularly vitamin D, almost identical to the placebo group. And so thinking about what is it about participating in this study? What is it about having additional action or attention around what for these participants is like life-impacting symptoms may be deriving that association. So we started to think a lot also about what are our participants doing to cope with pain? We also were interested in if they're seeing something different by age group, so those less than age 18, 18 to 25, and over 25. The majority of patients, and again, this won't be a surprise here, are finding that heating pads or lying down are beneficial. We do see the emergence of some differences by age group, but I want to be really cautious around overinterpreting this, that a lot of this is just what different people at different ages choose to engage in and report. And as you'll see for some of these, we have a highly significant age-specific difference for yoga, but there's hardly anyone in these categories. So, not overinterpreting, but really important for participant feedback. I just wanted to also finish with one of the important things about endometriosis is that when you start with a clinical population, particularly at clinics like Boston Children's Hospital and Brigham and Women's Hospital, we're very skewed by who gets there in their journey and gets an accurate diagnosis, who gets counted, what their characteristics are. And so we launched across the state of Michigan the WORK study, trying to now capture girls and young women across the state who are experiencing pelvic pain, maybe have never heard of endometriosis, maybe have never presented to a physician, but also trying to capture demographics that are often missed in the endometriosis-specific studies. So these are participants aged 12 to 30. They had to have reported within the last 3 months a NRS of greater than 3 for either dysmenorrhea or acyclic pain. And we got a pretty good, this is a heat map of distribution across the state of Michigan. We've successfully enrolled 1112, meeting our goal of 1,000. We closed enrollment just recently. We're cleaning this data right now. The average age was 23 at enrollment, and we're getting a pretty good distribution of certainly not as dominated by meeting now the demographics of the state of Michigan with respect to race. Also not the healthier, wealthier groups who tend to end up at the, again, endometriosis successful diagnoses. We also are very interested in, what their experience with pain, what their presentation is, who they've engaged as clinicians about. We're at just about 10% who are diagnosed with endometriosis, which is that magical 10%, but it should be much higher in this symptomatic group. And then also thinking about distributions of what types of pain they're having and the emergence of multifocal pain. One thing that's been very important is us querying with standardized tools about how they perceive their pain, how they engage with loved ones about it, how they engage in the workplace and at school and with clinicians. And we're seeing fairly high rates of discomfort, interestingly higher with other women and friends than with life partners and with clinicians, but still in terms of discomfort talking about pain with your doctor, we're at 35% who never or sometimes feel comfortable talking about it. We're also seeing a fairly high prevalence, about a quarter who feel isolated, feel that no one believes their pain. Again, not news here, but in the endometriosis world, it's often very skewed to those clinicians who are serving those with the highest access to care. And so I just wanted to finish saying, Andrew, and prompting our panel discussion, and really the spirit of these last 2 days is, it's such a wonderful field because you get to work with multidisciplinary people and have to bring really creative lenses to these complex associations. And there's truly an endless list of things that we don't know. I think the biggest take-home message for endometriosis-associated pelvic pain is to be humble in the face of complex biology that we just really don't understand. There's our team who have done tireless work to keep this large volume of data and samples and aims going forward. And thank you.
All right. Well, thank you so much, Stacey. I am delighted now to welcome Suzie As-Sanie up to the podium. Suzie is here at the University of Michigan. She is in the Department of Obstetrics and Gynecology. Suzie is a minimally invasive surgeon who has managed to maintain a wonderful research program and be a great mentor throughout a very long period of time. And she's probably done more to raise attention to nosoplastic pain and pelvic pain than anybody else I can think of right now. So I'm delighted to invite her here.
Well, it's definitely absolutely my pleasure. My biggest disclosure is that I've spent the past 20 years writing on the coattails of my amazing mentors who are all here in the first couple rows, and I truly do spend at least 50% of my time doing clinical work, and so I can bring in the clinical context, but I do want to say my biggest disclosure is that I'm not a neurobiologist, I'm not a neuroscientist. When I show some fMRIs, if you ask me to point to which regions are what, I'll be like, I don't know, ask him. So that is important to know. So I'm going to start with a really common clinical scenario that me and my colleagues see on a weekly basis, just to put it in context. And certainly in a world like this, in a room like this is not going to be any surprise, but these are the types of clinical scenarios that we face on a daily basis. So this particular patient, she's a 42-year-old G2P1, means that she's been pregnant twice and had one delivery, female who presented to our clinic having undergone a laparoscopy about 3 years ago with excision of endometriosis, and then reported that her pain recurred about 7 months after surgery. She is crying. She reports that she has daily pelvic crampy pain that's shooting. Her pain is worse with sexual encounters. It's worse with her menstrual cycles, but she also reports upon probing, because we don't always ask these questions, is that she has associated bloating, constipation, urinary urgency, and frequency. She cannot sleep. She's used most of her sick days at work, and her marriage is falling apart. She's had no improvement in pain with multiple treatments like birth control pills, nonsteroidal anti-inflammatories, and she's been using some oxycodone that she got from friends. And so the most typical thing that will be presented to us and my partners is she says, I am all done. She cannot live like this, and she wants it all out. And wants it all out means that she wants a hysterectomy, and for most people that means like, I want my ovaries out too. And so what do? Well, we certainly have the ability to offer surgery. We have medications that we offer, but I would say that it's really important to recognize that the evaluation and treatment of pain is probably one of the most poorly taught processes in medical school, in residency, and the vast majority of clinicians that you see out there will have little to no experience in the care and management of pain. We at the University of Michigan have probably one of the only pelvic pain centers across the state of Michigan. We have close to a 1-year wait to get into our clinic, despite having 5 clinicians and that see patients like this, and it's certainly no surprise that patients are frustrated. So today we're going to just talk a little bit about nosoplastic pain and the data that we've brought forth, specifically in chronic pelvic pain and endometriosis. And then I do want to mostly focus on what are the clinical implications and how can we apply this information to the daily clinician? And that's majority of the talks that I give are actually so much easier than this because I talk to mostly physicians, mostly OBGYNs, family medicine doctors, and I know pretty much more than anybody in the room about chronic pain, so I can say almost anything. And to a group of my peers who know a whole lot more about this than I do, you just correct me when I'm wrong. All right, so chronic pelvic pain has been defined by multiple professional societies, including the American College of Obstetrics and Gynecology, as non-cyclic pain. So the reason that that's distinguished is that we distinguish it from dysmenorrhea, which is pain just with your periods. And so that is a repetitive monthly pain, but in patients that have chronic pelvic pain, they need to have some type of daily or at least persistent component of their pain outside of their menses. And it's basically any pain that localizes to the anatomic pelvis, and it needs to be of sufficient severity to lead to some decrease in quality of life. It is very prevalent in our patients and in our clinic. So we estimate that anywhere between 15 to 25%, so up to 1 in 4 women in reproductive years, so from menarche to menopause, experience some type of pelvic pain during their life. And in one study that we did with one of our prior fellows, we found that in a cohort of women undergoing hysterectomy across the state of Michigan, up to 40% of patients reported moderate to severe pain prior to their surgery. But the really important thing, and the thing that I want to point out as a clinician, is that chronic pelvic pain is a symptom. There are multiple conditions that cause chronic pelvic pain. So there are gynecologic conditions, there are urologic conditions, gastrointestinal, musculoskeletal, as well as peripheral nerve injuries that can cause chronic pelvic pain. And one of the most frustrating and difficult things is that the symptoms across all of these conditions overlap tremendously. So for example, in gynecologic pain conditions, the cardinal symptoms are things like chronic daily pain, pain with intercourse, pain with menses. So here, but you actually see all of these symptoms in underlying urologic conditions. It's very common, for example, to see a patient with painful bladder who says that her bladder pain symptoms actually flare before and during her menses. This is true for irritable bowel syndrome as well as musculoskeletal pain conditions. And then all of these gynecologic conditions can have underlying bowel symptoms as well as bladder symptoms. So one of the most common things that we see is I have pain with bowel movements, and the question is do you have bowel endometriosis, or do you just have irritable bowel, not just, but do you have irritable bowel syndrome, or do you have both? And so we see that across all of these conditions. To add to the complexity, this is not an audience that I need to say anything about chronic overlapping pain conditions, but not only do the symptoms overlap, the more likely you are to have multiple symptoms that contribute to your conditions. And the longer you have those symptoms, the more likely you are to have another chronic overlapping pain condition. So even if you do have endometriosis, you're more likely to have multiple of these other conditions. And I know that Stacey already referred to that. So Stacey and I, we spent the evening last night together. We probably should have coordinated our slides a little bit more, so I don't need to tell you that endometriosis is one of the conditions that we see and treat most often. As gynecologists, I think the key thing about this is that it is considered an inflammatory condition, so there is significant pelvic inflammation. It is estrogen dependent, meaning that it is stimulated by our ovarian estrogen production, and it's the presence of endometrial tissue outside of the uterus. The key, and one of probably another most frustrating things is that we do not have a non-invasive way to diagnose this condition. So the only way to make a definitive diagnosis is to do surgery. So we have imaging that can sometimes diagnose it, but it really only diagnoses the most severe, deeply infiltrative forms. But the most common form of endometriosis, as Stacey pointed out, is the superficial peritoneal disease that you cannot see on any form of imaging. There's no biomarker, there's no blood test that is reliable. It is very prevalent, like I said before, so I will skip this. And what I wanted to show is what it actually looks like at the time of surgery. And so endometriosis is staged many different ways, but the most common way that we stage it is the American Fertility Society staging. So there's stage 1, 2, 3, and 4, with stage 1 being the most mild. And so what you see here, and I think this will loop, if not, I'll go back, is that this is a uterus in the middle at the time of a laparoscopy. This is us pulling up the right ovary. These are all patients that consented to us using pictures. And there's this tiny little lesion here, there, so that's superficial endometriosis, but the very rest of the pelvis actually looks almost essentially normal. So if you're not actually looking for that lesion, it's likely to get missed. The next case is case of stage, probably qualifies as stage 4. So the uterus is there, but both of the ovaries are globbed to the back of the uterus. The fallopian tubes are dangling there. The bowel is right underneath there. So endometriosis, you can see here, causes a lot of inflammation, adhesions, and then the lesions there are on top of the ovaries in the back of the uterus. And then in one of its most severe forms, this is a case of stage 4 endometriosis. Not only do you have those peritoneal lesions, you have this very large ovarian cyst. It's a chocolate cyst, so an endometriosis cyst. We lift it up. You can barely see underneath the ovary because it's loculated in with adhesions. There's a small little uterus there. This is all like superficial endometriosis in front of the uterus. And then we lift up the uterus. You can barely see the left ovary, and it's all loculated with adhesions. Now, Stacey mentioned this, but this is, the third bugaboo in our clinical world is that, logic would say that if you looked like this, you would have little to no pain at all. If you looked like this, you would have daily severe pain. But we know, like every other chronic pain condition, there's little to no correlation between what we see and what we find, and it's actually not that uncommon for us to discover this by imaging for other reasons like infertility, and patient has little to no pain at all. So as I mentioned, endometriosis is a chronic inflammatory condition. There is a lot that we know about the lesions. The main thing that to take away from this slide here is that the primary hypothesis for most forms of endometriosis is that it probably starts out as retrograde menstruation, so endometrial tissue backflows through the fallopian tubes, deposits into the pelvis. This actually happens if you do a laparoscopy in a woman during the menses. You will see retrograde menstruation in 9 out of 10 women. The difference, though, in patients with endometriosis is they have dysfunction in their immunological biological system in which there is inflammation, there is neovascularization of these lesions and infiltration of these lesions with nerve fibers. And so we know this, and so this is just showing that there's a lot of evidence to confirm that endometriosis lesions are innervated by a multitude of different types of sensory fibers, and that these and that endometriosis lesions release pro-nociceptive molecules that can stimulate these fibers. And so the traditional way to think about endometriosis, the way that we've all been trained, is that it is a nociceptive pain condition caused directly by the lesions. And so because of that, as gynecologists, we treat the lesion. We treat the lesion with hormone medication. So like I said, it is a very estrogen-dependent condition. So any type of hormone that overall lowers your estrogen levels is traditionally the way that you treat the lesion and or do surgery. That obviously does not work all of the time. This is not a group that I need to remind that. And so what do we actually know about this? And so these are some studies that we did close to 10 years ago with my amazing mentors here that looked at, at first trying to establish that endometriosis, at least some patients with pelvic pain and or endometriosis have central pain amplification. And so what we did, and I think this is one of the many reasons that I like to study chronic pelvic pain and endometriosis, outside of it being clinically relevant, is that we have perfect internal controls. So what we did was we recruited patients according to a 2x2 inclusion and exclusion criteria. We included patients that had both chronic pelvic pain as well as endometriosis. We included patients that had chronic pelvic pain and surgically confirmed absence of endometriosis. And then we compared those to patients who had endometriosis but little to no pain at all. Most of these patients actually had stage 3 and 4 endometriosis, but were discovered, in the course of fertility treatments. And then we compared them to healthy controls. And you'll not be surprised by any of these findings. We did QST, we did neuroimaging, and what we found is that in patients that had pelvic pain, they had increased sensitivity to both pain and sensory stimuli, both in the pelvis as well as outside of the pelvis, with the traditional thumbnail squishing that was developed here. In neuroimaging studies, we saw what we see similar to many other chronic central pain conditions, that there was, when we looked structurally, decreased gray matter volume in the pain regulatory regions, including the thalamus, the posterior insula, as well as the cingulate gyrus and putamen. And then in connectivity studies, there was increased connectivity. Actually, this also included looking at the insula, and we found increased levels of excitatory neurotransmitters in the anterior insula, not the posterior insula. We have to ask Rick Harris why we only saw an anterior insula and not the posterior. I know that that's something of interest, and that there was increased connectivity between the anterior insula as well as the medial prefrontal cortex. I think the interesting thing from a clinical point of view is that when you looked at the pelvic pain patients, regardless of whether or not they had endometriosis, those patients looked similar and they looked different than the healthy controls. But when you looked at the endometriosis patients without pelvic pain, they actually looked very similar to controls in every single way except for one. And this was one thing that we actually did not expect to find at all, and probably one of the most cited things that surgeons love to hear about when we present this to them is when you look specifically at those pain-free endometriosis patients, in QST, they look like controls. In the anatomic, the gray matter volume studies, they look like controls. In the functional brain imaging studies, they look like controls, all except for one thing. And these patients had increased gray matter volume in the periaqueductal gray. And for those of you, about this a whole lot more than me, but in a basic kindergarten level as like a clinician, the periaqueductal gray, in my understanding, is the area that is really important in descending pain modulation. And so potentially this might be explained that despite having significant pelvic pathology, maybe one of the potential reasons that these patients do not experience the same pain as those with similar pathology is this adaptive change in the periaqueductal gray. Now, I don't think that this study has been replicated in any other cohorts, and so I'd certainly be interested in hearing what people think about that, but that surgeons really think that's super interesting. Now this is a place where this slide is courtesy of my dear friend and collaborator, Dr. Schrepf. I will again give a very basic understanding of this, but I think this is some of the earliest work that we've done together and then sort of launched into two big grants that will be starting in the near future. So Andrew, you can jump in anytime I say something wrong. But one of the things that's been, and one of the reasons that this collaboration has started is this really important investigation of what is the role of systemic inflammation in the development of chronic pain. So as I said, we know that endometriosis has a very important and well-established mechanism of local pelvic inflammation. There are some studies that demonstrate that there's elevated systemic inflammation in these patients as well. And many other researchers, including those in the MAP network, have demonstrated that this might also be important in nociplastic pain. So this slide is courtesy of Andrew, and what he designed it to show is that what we know is that there are microglia and astrocytes in the spinal cord that modulate communication. Those are the cells in the green between nerve fibers, and these microglia and astrocytes express TLR4 receptors, and that when you stimulate these receptors, they can increase the secretion of these pronociceptive molecules, and this is thought to be one important potential mechanism by which patients can develop nociplastic pain. One of the ways that they've studied this before, and one of the ways that Andrew's studied this, is by looking at LPS-stimulated response to TLR4, and they did this in the MAP research network. And what they found is that in patients with urologic pelvic pain, for every one standard deviation increase in TL4 reaction, there was a 1.6 times odd of developing widespread pain. And so the thought being is that this is potentially a mechanism that might distinguish those patients with localized pain versus widespread pain. And this beautiful, body map here is aimed to demonstrate this. And so these is the area, these are patients that have a low TLR4 response, and you can see that most of these patients have relatively localized pain. This paper was published in 2021. And then what you see, this is in contrast to those that have a elevated or high TLR4 response, and those tend to be more consistent with widespread pain. So in an ongoing R01 that were recently completed recruitment for in collaboration with Dan as the co-PI, we recruited patients undergoing hysterectomy with or without chronic pelvic pain. We collected a lot of data prior to surgery, including a lot of different PROs. A subset underwent blood samples for the markers of systemic inflammation. A subset underwent fMRI and QST. And then at the time of surgery, we collected a lot of specimens, and then we're following participants for up to 12 months after surgery. And so Andrew and team looked at this data as preliminary data that has been helpful in us securing additional grants. And what he found was that in patients with pre-existing pelvic pain scheduled to undergo hysterectomy, there was a relatively strong correlation between their pain symptoms and MIP-1 receptor alpha levels in response to the LPS-stimulated findings. And this looks he then pulled the data from MAP, and patients that had urinary chronic bladder pain and endometriosis saw a very similar relationship. So the higher the level of pain symptoms, the higher the MIP-1 alpha response. He then examined this relationship between provoked systemic inflammation and functional brain imaging. They conducted a seed region to whole brain analysis in those patients. They used the same seed, I believe, that Jason described in his study in the primary somatosensory cortex. And what they found is that as MIP-1 alpha levels increased, and so by extension, based on the prior slide, by extension, the severity of pelvic pain and the severity of comorbid pelvic pain and visceral pain, the pelvic S1 became more connected to the medial prefrontal cortex. And these findings are actually not thought to be spurious. This is very similar to what Andrew and Neil and others have published in 2018 in a rheumatoid arthritis cohort. And so again, really just pointing that if you look at patients that have chronic widespread pain, the underlying mechanisms are similar. All right. So in terms of clinical context, I mean, we do ultimately still spend most of our time taking care of patients, and how do we help them? And one of the things that I think that's most challenging in our field, and this is not unique to our field, but unique to any surgical field that uses surgery to treat pain, patients I don't say they like, patients want to have surgery to treat their pain, and many times it's very appropriate. But what's not always appropriate is doing multiple surgeries over and over again with getting the same result, which is not improvement. And we unfortunately have that ability to do sometimes more harm than good. And this is unfortunately really driven by social media. There is a very strong social media presence in probably in any chronic pain condition, and specifically in the world of endometriosis, the social media presence has a very, very strong support of surgical therapy for endometriosis. And I have colleagues who've literally been harassed. I mean, we had actually a Facebook post not that long ago saying, don't go to the University of Michigan. They will just give you hormones and try to send you to PT for your pelvic pain instead of doing surgery. And there are many, many reports out there. I finally had my 14th surgery for endometriosis, and that surgeon promised to cure me. So in terms of take-home messages that we try to resonate with other surgeons is that all of these mechanisms probably exist to some degree across the population of women with endometriosis. There are likely those that have entirely a peripheral nociceptive factor. You do surgery, you give them hormones, their pain is better, and you're done. And then there are the other patients on the other extreme that have endometriosis. These are actually body maps from patients that we've seen in our clinic, and my guess is that if I offered that patient surgery on the far right, she would be the same, if not worse, after surgery. The problem is that we don't really have a very good way of distinguishing these patients. They tend to be very common in our clinic. About 40% have widespread pain. And we don't have a good way of distinguishing who is going to get better from what type of treatment. So as I said, chronic pain is a symptom. It can lead to central sensitization. There's all of these other overlapping conditions that can cause chronic pelvic pain, and they're all mediated by external factors. And so when you see a patient, it's really hard to distinguish where they lie on this spectrum and what you should be treating, even if the endometriosis is present. I'll skip this because I think we're almost done, but I think this is, we need to be done. This is really just 2 small studies that we did really looking to show that even if you do get better after surgery, how quickly you get better, how likely you are to get better varies according to your pre-existing degree of nociplastic pain. So this is a study that looked specifically at opioid use and daily pain after surgery. The patients in the blue were in the highest fibromyalgia tertile, and what we saw is that they used more opioids, but despite using more opioids after hysterectomy, they had pretty severe pain after surgery. This was another study that looked at the incidence of persistent pain about 6 months after surgery, and we pretty much were able to replicate what Chad Brummett and Dan Klaw found in knee and hip arthroplasty, that the pre-surgical degree of your fibromyalgia was strongly correlated with the likelihood of persistent pain after surgery. And then the things that we usually think about clinical factors like adenomyosis, like how do you have uterine fibroids, how you did your surgery actually did not predict the likelihood of persistent pain after surgery. And so this was Chad's study there. So in terms of next steps, we just finished recruiting for our hysterectomy study that I mentioned before. So there is a lot of work to be done to clean and to analyze the data, but we're super excited about that. We just had an R01 funded, very excited to work closely with both Dr. Schrepf and Chelsea Kaplan, who you've heard some of her work here before. This study is going to capitalize on collaboration with Stacey Mismer as well as Katie Terry, who Stacey mentioned previously. And we're going to try to replicate what Stacey's group has done at Boston Children's Hospital and conduct a prospective cohort study recruiting adult women who've had pain onset since adolescence and look at many of those proteomic markers and imaging markers to see the relationship. And then we're really hoping in the next couple months to get notice of award for this grant that was scored really well. Our biggest challenge is that we use estrogen suppression like water in a gynecologic clinic. If you have menstrual pain, you get treated with estrogen. Patients, it can be highly effective, but no matter what you're treating, about 25% of patients don't respond. We don't know what the impact of hormonal suppression is on the central nervous system, and so this is potentially going to be a randomized clinical trial that will randomize women to hormonal suppression versus not, and we will be able to study the impact on nociplastic pain both before and after hormonal suppression. So thank you for your attention. I cannot be more grateful to my amazing group of mentors who really have been so generous with their time and their support, and the growing collaboration with Stacey's group, as well as Rob Taylor, who receives lots of endometrial biopsies from us and is doing his basic science thing with them. All right, thank you.
Okay, awesome, wonderful. Can I have Stacey and Jason join us up front? And we have about 10 minutes for questions, and would love to hear your thoughts. Yeah.
I have a question for Stacey. So for the longitudinal study and the one that you just finished, were any of the patients receiving any other pain modalities like hormones or pelvic or physical therapy or anything else in that time frame?
No, great question. So the question is, what other treatments, in particular, pharmaceutical, PT, treatments, all right, we're trying again. That the patients in the longitudinal cohort were receiving. So a majority receive hormonal care. Very few. Can you hear me? Okay. Yay. Very few receive PT. We have a subset who are participants in a study within the pain management core, which is independent from the gynecologic care core, and they also are participating in a study where QST and other functional pain work and various interventions, CBT and several other things are being trialed. But for the most part, they had surgery at start. We have 49 across the 10 years of follow-up who've had a repeat surgery, and then about, at one point or another, 85% have had some hormonal treatment.
A question for Jason. I wonder if you could tell us what you think it is about surgery that might be really good for pain. Is it that it's sort of a bilateral activity? Is it that you have to engage in focus and balance at the same time? Any ideas?
Yeah, I would say that my excitement about the VR component is that we can try to tease that apart. That's often a problem in these like holistic approaches, that it could be one of many things and it's hard to tease it apart. I would say my preliminary hypothesis is that it is an activity, although not the only activity, that promotes a very strong external focus of attention. You put somebody in a completely dynamic external environment and there's very little neural resource left over to scan the body for potential threat, because all of the potential threat is outside, and that's a good thing. And perhaps repeated exposure to that can help promote positive neuroplasticity and downregulate maybe some of the central sensitization that's happened. It's speculative, but hopefully we'll get to see a little bit of that in this study.
Chad?
Yeah, so I have a question for Suzie. Suzie, great talk. I'm trying to, how has this body of work influenced gynecologic care? In other words, are you seeing this in GYN care, whether here at the University of Michigan, when your trainees, or and nationally, where are things now as people think about nociplastic pain or really differentiate people based on phenotype, or are we still have a long way to go?
I mean, I think, no, that's an excellent question. The question being is sort of where are we right now in clinical practice and how's this influence? I mean, I think it's had a tremendous influence. I don't think I need to explain centralized pain to gynecologic surgeons anymore. You see it referenced in other talks. Other people are beginning to study it. I think when we started this 15, 20 years ago, it was extremely unknown concept and actually a lot of pushback towards it. And I think that is less. I think the challenge is still more with, well, how do we apply it? How do we know whether that's what's going on with our patients, and how do we decide what treatment to offer them? And I think one of the biggest challenges, though, where we have far more work to do is how do we convince patients? And having that dialogue that this is one important component to pain management. And I don't know what it is about the patient. Stacey might have some ideas about the social network that we work against, especially in inpatient groups that are extremely anti-pharma, anti-integrative medicine, and very, very pro-surgery. And maybe you see this in other surgical specialties, but in our world, it's, we have colleagues that get hate mail for proposing a clinical trial on the utility of surgical excision of endometriosis. So there's a lot of work to be done there.
Yes, Frank.
Hey, Jason, another follow-up to that other question about the surfing. As a practical question, I'm really intrigued by the idea. I think it's phenomenal. But I was having a conversation with Dan, I think around 2005 when I first met him, about why we didn't just do more exercise interventions to get people 5 miles to get better. And he's like, well, there's this problem where many of them have to pace activity or else you'll flare them. And I think about that right now, as much as I'm really intrigued by this idea of like, get this intense focus. Many of our patients who have a major injury, like an accident, I had a patient once who was mowing a lawn down a slope and fell down the lawn. The lawnmower sailed over her head. She fell off the bottom, retaining on the bottom of the slope. Came in a horrible pain flare. And I said this thing, I was like, that sounds exactly like a person falling off a surfboard. How are you guys, describing it in great detail, I did like weeks of truthful injections to get her to calm down, but like, how do you guys account for something like that where this will actually go the opposite direction, where the surfing will cause horrible pain flares? Because at first I was like, this makes complete sense, but I was like, but that woman's exactly what she was doing. She was just surfing down a grassy slope. That's how you guys are.
Well, surfing a lawnmower down a grassy slope.
How you guys are making sure you have the right selection?
Yes, we're carefully screening the patients that they are comfortable and have some familiarity with being in the ocean, so that it's not a completely scary place for them to be. And then it's interesting over the last decade, partially inspired by the work in PTSD and veterans. Quite a number of surf therapy organizations have emerged really across the world, but particularly in Southern California. And so they've sort of developed protocols for how to identify a safe beach, how to put people in the environment that is fun, exciting, and interesting, but not takes the danger out of as much as possible. And I think another important thing is that the therapist really allows the patient to. It's not a surf lesson. It's a more of an immersion in that environment, and very much allows the patient to choose the level of engagement that they want. If they want to float on the surfboard in the water, that's great. If they want to find a big wave and surf it, that's great too. So I think with that combination makes it, there's not zero risk, but it's a manageable risk.
So I'm going to make a statement, and then I want to ask you another question, which is that I showed the coping mechanism things for benefiting pain that were reported, but in terms of things that worsen pain, the adolescents dramatically are more likely to report that exercise worsens their pain. And so again, whether it's actually an age window, or whether it's a perception tied in with, say, school and kind of activities that they don't have as much control over compared to an adult, but we definitely see that differential. I'm curious, Jason, and I think you just alluded to this, of if something like paddleboarding or something that still is a kind of balanced, focused, full body thing, and it comes up, Kat Correa is now a faculty member at Amherst, but did a lot of the statistical analyses for some of our early work. She volunteers at and helps to run a summer program for really severely physically disabled adults. And one of the things that is most beneficial in kind of stress and pain expression has been particularly paddleboarding, and it can be retrofitted for those who either are paraplegic or have other dysfunction, and I wonder if that fits.
It does. Yeah, that's, and one of the first iteration of the VR that we're developing is actually a paddleboarding setup. It's a little bit simpler. You don't have to solve the dynamic problem of giving them proper body weight control and support while they transition from laying down to popping up. So I think we'll actually be able to explore like what elements are most beneficial, because I think I totally agree we can simulate that immersion in a much sort of simpler, less dynamic environment and then scale it up as the participant wants.
All right, probably time for one more question. Diva?
My question's for Suzie. In the patients that you've been able to convince to treat their nose with plastic pain and not surgery, what have you said or done that has
No, that's a really good question. So the question is basically for those who have been open to exploring treatments that address nociplastic pain, or the non-straight surgery or hormones. What have we done to sort of convince them? I would say that the key has been for those who have received the standard of care. We've not had anyone where a starting point was different from the excision surgery with and without hormonal treatments. So those who have been keen are those who still are struggling. Our dietary supplement was specifically those who were continuing to struggle with life-impacting pain, and this is something that they were open to trying. And so the referrals into the pain clinic, and particularly the QST evaluations and things like that, have really been those who have been with us for a while and trust us, but are clearly still not having adequate life intervention despite receiving all of the standard care options.
Okay, thank you so much. That was a wonderful.